Just not listening to anybody saying that it's impossible. Everything is possible. You cannot accept no for answers, and you cannot accept failures. Medicine is not for those people that are looking wealth. It's not business. You cannot become wealthy in medicine. But for young people, don't worry, they will. Just go. Persistence, repeat. Then it comes by itself. Canadian graduates were reluctant to go to forensic psychiatry because you had to work with criminals. And my supervisors were younger than me and less experienced. You have to put your ego into your pocket and forget about who you are and what you did before. You know, there is a big difference between advice and psychoeducation. So when somebody has, let's say, depression, moderate or moderately severe or severe depression, just psychotherapy is not going to help. And you know, yes, I like partying, I like sometimes a little bit of cocaine, or sometimes marijuana, and all this kind of stuff. And you're telling me you don't want to take antidepressant medication, but you're using all these drugs.
Hello, my name is Soroush, and welcome to another episode of Beyond the Scrubs on CubeCast, the new and original podcast show. Please join me as I go behind the scenes in the healthcare industry, where we invite doctors, therapists, healthcare providers, where we learn about their original story. It's an opportunity for us to learn about their ups and downs, their challenges, their success stories, but more importantly, their advice to the next generation. Tonight's a very special episode for me because of the guest that we have. He's a very interesting and inspiring person. He's a psychiatrist and an assistant professor at the University of British Columbia Department of Psychiatry. He's got a very interesting story of being born in Ukraine and having studied medicine in Russia and practicing there for 10 years before immigrating to Canada. As an immigrant doctor, had to restart all over again. So it's a honor and privilege for me to have Dr. Alexander Levin here tonight. Thank you so much, Alexander, for coming in.
Thank you. It's a pleasure to be here, and thank you for inviting me.
Thank you so much. So without anything, can you tell us about your profession, what you do, who you are, and what psychiatry is all about?
At the present time, I'm mainly working in my private practice. It's a Fairmont Medical Building. And I also continue working on call at the Vancouver General Hospital, mainly providing consultations for patients that are hospitalized for different reasons than psychiatric reasons, like emergency, all medical conditions, neurological conditions, physical trauma. So once or twice a month, I'm on call for ICU units and other acute care medical units, providing consultation for psychiatric patients that they are hospitalized for other reasons. But in my main practice, medical practice, private practice, it's in the Fairmont Medical Building. I am mainly seeing now patients for treatment, psychiatric patients referred by different family doctors and the different agencies.
Okay.
I'm still doing my assessments in forensic psychiatry that I was initially trained in, and I still do it, but not as much as before. And it mainly comprises assessments of personal injuries cases and still some criminal cases, but not as often as it was before.
Okay, so a bit of mix of everything, you know, you're doing a lot of, but majority of the cases that you see in your private practice, what kind of cases, clinical cases are those? I'm now working as a general psychiatrist. Okay. I'm not specializing in any particular area, but as a general psychiatrist in outpatient setting, I'm mainly seeing patients with depression, anxiety, mild bipolar disorder or bipolar II disorder, personality disorders, and neuropsychiatric patients. Neuropsychiatric patients, it's a psychiatric patients that develop psychiatric complications of general medical condition or neurological conditions such as epilepsy, chronic pain conditions, fibromyalgia, chronic pain, and the similar conditions. So they often come to my practice, referred by family doctors, when all other venues of medical care were exhausted. Yeah, those are some of the cases that I see as well, chronic pain. So
absolutely.
I think there's some comparisons here or there. But so how many years have you been in practice, Alexander?
So I graduated medical school actually in Russia, not far from Moscow. Yeah. And I graduated in 1981.
Okay.
So since then,
this was during the Soviet Union era,
right? It was Soviet Union, and I completed my training in psychiatry. Then I completed additional training in forensic psychiatry. A few months of training at the Forensic Psychiatric Institute, Serbsky, in Moscow. It's well known, but on the Western world, it was infamous, you can say, but academically it was extremely good school. Okay. And that's how it helped me actually to find a fellowship in Canada, because when I came to Canada, I didn't have any English.
You didn't know English?
Almost a little bit, like after university, you have minimal English in medicine that you can translate scientific work, that's what we are required to do. But I didn't have much of spoken English. And when I was learning English, gradually somebody introduced me to a forensic psychiatrist, head of Forensic Psychiatry Commission on British Columbia. It was Dr. Eves, Derek Eves. And he was from Great Britain.
So when
and suddenly he apparently knew my supervisor from Institute of Serbsky from Moscow.
So he had heard of them.
So when I told him about it, he said, "Hey, I'll take you as a trainee." And that's how my career in psychiatry started. But at that time, I had to learn English to pass my first licensing exam. And then, because of lack of forensic psychiatrists in Canada, nobody wanted to be in forensic psychiatry at the time because they were working with criminals. He gave me some temporary position.
Okay, so it kind of worked out for you, your background.
It worked out for me, but I didn't have enough English, so I was at night writing reports, because I had to write reports for the hospitals, for the court. It calls fitness assessment. So before somebody goes to court to face a judge, the judge should know that the patient is fit to stand trial. So he's not completely psychiatrically ill and doesn't have sound judgment. So this relatively simple assessment, I had to do some of them, but I couldn't write. So
how did you overcome that challenge?
That's the challenge that probably will face many immigrants who are trying to go to school, that you have to spend so much hours, extra hours, that you are writing, rewriting, and doing your reports or whatever you do in English, and you are rechecking that it sounds good and it's good quality of English. So that's how I started. And even at that time, I was told that I shouldn't even have any hopes because, at that time, 30 years ago, rarely that foreign graduates would be accepted to residency, especially to subspecialty, like forensic psychiatry, being a dermatologist or eye doctor. It wouldn't be incredibly difficult.
Yeah, it's still difficult, but I can imagine 30 years ago was even probably impossible, as you said.
That's right. I was told that because the influx of foreign graduates was so small because of the immigration limitations, so that it was only graduates from United States or UK that were coming here, some from South Africa, but English Commonwealth countries. And for somebody who didn't know English, it was completely very challenging. But the idea for your audience is that you never give up.
You have to push through.
Doesn't matter what they're saying. You can fail exams many times. It doesn't matter. You just go to proceed with what you would like to do, and they persist, and you will succeed eventually. Just not listening to anybody saying that it's impossible. Everything is possible.
Nothing can happen, but you got to push through.
You have to push through, and you cannot accept no for answers, and you cannot accept failures because it's temporary.
That's a very good advice to the next generation. You just keep going through. And also immigrant doctors, for example, that are coming, over.
Absolutely. And that's once again, the system here, you learn not to fight the system. You learn how to work with the system. And working with the system is only persistence. And then when you're becoming a part of the system, that's when you're passing exams, when you're finding a job, and establishing yourself as a medical practitioner eventually. If you are out of the system, it's very difficult to break in, but you're not fighting again. You're just working with the system, getting in the system, and learning how to work with the system to succeed. But that concept is very important because it helped me, even though I didn't know this concept. But when you have even training for free or working for free for the in the system. That's your first step in.
Yeah, you have to pay whatever dues you have to pay to get into the system, work with the system, and eventually your persistence and hard work will pay off.
Right, and that's where we're talking about the difference, let's say, between European and the East European training and Canadian training.
So can you tell us a little about that? So before anything, you started practicing medicine in 1981 in the Soviet Union.
Correct.
And then you came to Canada in the 90s. Is that right?
When I came to Canada, I had already 9 years experience working in psychiatry.
Okay.
Now, I worked in Russia. There is a system. When you finish medical school, you become a doctor. You have to pay back for your medical education.
Because it's free, right?
Because it's free.
Okay.
At that time, it was free. And you have to pay by going to remote area where there is no doctors, and you're working as a physician, serving back, providing care to the community.
Society.
And usually it's 3 years, a very long time. So I, with my wife, we went to a very remote area between Moscow and Smolensk, very small town. And I was a psychiatrist, but I had to be on call and to work as a neurologist, as a general, as a surgeon, sometimes assisting, not as a surgeon, but assisting suturing, assisting to the surgery because there was nobody who could do
lack of any sort of medical professional in those small communities.
And it was a couple of times that I had to go into the villages and to receive a labor when a child was born, which for me it was, and I was only 25 years old. So it was
a lot of stress.
Right, and it was amazing in terms of my experience now that I'm looking back, because I'm teaching medical students in Canada, in UBC. I cannot imagine my students on their own to go to a remote area on their own by themselves to help somebody.
Yeah, it's a different generation.
Labor. It's just completely... I cannot imagine, but we had to go through this process. And then, after this period of time of paying back to the community, I went to Ukraine, back to my parents, and I was working as a psychiatrist in the ambulance. Mm-hmm. In Canada, we have similar services. It calls CAR 89 or CAR 87, there are different services, where a psychiatric nurse and police officers sometimes, they come into psychiatric patients' home when there is agitation or violent behavior. In Russia, we had a psychiatrist also coming inside of this ambulance.
Oh,
so we could provide services, meaning that legal services, provide mental health act certificate on place, so then police can apprehend the patient. Mm-hmm. In Canada, police has rights. They have their own certificates that they can issue for temporary hospitalization of a patient until psychiatrists can see this patient. So it's legally a little bit different system. But in any way, it's still that the psychiatric services for acutely disturbed psychiatric patients are provided on the spot. And I worked for some time, and this is, I was working in Dnieper. It's a 1.5 million people, big city.
Yeah.
And if I go on a call, like in an ambulance, I wouldn't get out of the ambulance car from 11 at night until 7 in the morning. You go.
Back to back.
Back to back. And when I was working in a psychiatric hospital before that, it was 3 doctors, psychiatrists, for approximately 100 beds unit, psychiatric.
Wow.
So the volume of patients that you're seeing, we're not talking about care, about the quality of care at the present time, but the volume of patients the doctor has to see, it's incredible. Mm-hmm. So when I initially came to Canada and I was told that we're seeing only 1 patient an hour,
it was there. You're like, what's going on?
It was very nice.
Very
breeze.
different, complete different systems. Yeah.
But from another side, it's also challenging. That my experience of seeing so many patients gave me maybe not as much as knowledge, but as experience to see patients and communicate with the patients with psychiatric conditions that are universal. If somebody has delusions, hallucinations, or severe depression, they're the same everywhere.
Yeah, it doesn't matter where you're from. Yeah, it's very
That's right. The cultural difference is huge. So after working in this kind of hard environment, and the perestroika was coming. We decided to move to Western countries, and we came to Canada. So my wife is also a physician. She was an eye doctor.
Yeah,
but
like an ophthalmologist.
Ophthalmologist, right? It's operating ophthalmologist. But
Yeah.
when we came to Canada, we realized that the reality is it's impossible to get through the medical education for two of us. And we decided, she agreed to take this sacrifice because the probability of her becoming an eye doctor here was significantly less than me to become a psychiatrist, because we realized that they need psychiatrists in Canada at that time.
But the probability of the other side was probably close to zero, right? Very, very low.
Right. Even with all respect that we decided that, we shouldn't listen to anybody, zero chances, we still should push. But from two of us, we needed to choose. And that's why we decided she wouldn't. But being a surgeon, she also had exposure to pathology and lab medicine. And she was lucky that UBC at the time, and that was Dr. Devine. She's well-known scientist in blood supply and the blood work. So she accepted my wife as a lab doctor, and she started working at the UBC in research, and she still, until now, is there, just recently leaving this position. But for 25, 30 years, she was at the UBC at the blood supply services.
Wow. So there was she just chose a different avenue of...
Once again, never give up.
Never give up. Use your experiences.
Find other venues, find other opportunities in medicine. It will work. And that's where we come into a question about financial rewards. Definitely, physicians in Canada, they rewarded very generously, in my opinion. Many doctors will be probably...
compensated generously compared to what your experience was.
Right, no comparison for now, but maybe many Canadian doctors will disagree with me, because there is a significant overheads, expenses.
Yeah.
There are taxation system and everything else. But from my perspectives, it's a very generous compensation. And it provides me, at least, and physicians in general, with a very comfortable lifestyle. And comfortable lifestyle, it doesn't mean wealthy lifestyle.
No,
and that's why I would like to say that medicine is not for those people that are looking wealth. It's not business. You cannot become wealthy in medicine. And even if you're earning a lot of money, you don't have time to spend them. So when I came to Canada, not only that I had to...
That's a very powerful, strong statement. That's very...
But if you talk to general... Like, I know that you interviewed Dr. Cates.
Yeah, Michael
and
Cates.
If you talk to Dr. Cates...
he said the exact same thing. He said, it's not for making money. You have to... So the person that... because I asked him what kind of a characteristic or person do you have to be to pursue medicine. And I think... The top three things that he said is that you have to be very, compassionate, have empathy and understanding, and want to help people, right? And that's the reason you go into medicine. And when I asked him about financial stuff, he's like, that's not what you go into medicine at all.
Absolutely. Yeah. And Dr. Cates was and is my mentor. He is
really? One of my mentors?
Right. He's a great doctor with a good sense of humor.
Yeah.
And that's why I'm saying that he is from the same generation of physicians that I am. When we're going to medicine because of our aspiration to help people, who are suffering, rather than making money.
Do you think that now things are changed a little bit, where some people or students are going into medicine because they look at the lifestyle and the fact that you said, Canadian doctors or Western doctors get, compensated, generously?
Right. I've been teaching medical students since 2002 approximately. And I would say that in the last 15 years, since 15 years ago, situation has been changing significantly towards medical students coming, looking for business opportunities in medicine, rather than serving or providing services and care to people. And when I introduced myself to medical students, I always kind of present my background, and it was a little bit fun that, I'm probably a little bit harsh because I'm Russian, I'm straight, I'm direct.
Straight to the point.
No, and they're right, and I am from forensic background. I can see through all of you. And but then
they probably get scared right away. Like,
maybe.
I'm looking in your eyes. Right?
But then I'm saying, let's talk about why you came here, why you became in medicine. And many of them will saying that, okay, I'm going to dermatology, I go to surgery, I'm going to family practice. Why? I just feel there's something about medicine. Nobody anymore saying, by my character, I like to care about people, I like to help people.
So you hear that a lot less now?
No, it's not existent anymore. In my limited amount of interviewing medical students, it's very, very little, and no interest in psychiatry. If previously,
why is that? Why is
difficult to say? But if previously I would say, my goal, because I was teaching clinical skills, interviewing clinical skills, I'm saying my goal is to teach you not only clinical skills that you're empathetic to patients, but I would like you to learn psychiatry, to like psychiatry, and to go to psychiatry. You don't go, fine. But as a general practitioner, you will have 40% of patients in your outpatient clinic, psychiatric patients.
Yeah, and mental health, any sort of like psychiatric issue, I think comes with a lot of conditions as well. And people have a lot of things that they deal with every day.
But there's a well-known statistic that 40% of patients coming to GPs, family doctors, they have underlying psychiatric conditions that partially responsible for the complaints of medical problems. So if you don't know how to interview this kind of patient, you're not going to help with the physical problem.
So you've seen that there's been like a decline of medical students wanting to go into psychiatry.
Very much, significantly declined. Difficult to say why, but you see, the fact that compensation for Canadian doctors, American doctors is so good, comparing with Europe and Eastern Europe. So even in England, in UK, you're not getting compensation that you get even in Canada, in general.
Yeah. That's just true.
You're not talking about all other countries, Germany, because as a part of my training, I was doing research in Europe as well, in forensic psychiatry with Dr. Eves. And I had exposure to psychiatrists in Germany, Finland, Sweden, so all of them were looking at us, that it's millionaires. So this rumor.
I think it's everything's perspective, right?
Even though it's not true, but the rumors, this flavor. So a lot of medical graduates from around the world come into Canada, to the United States, with an idea to become wealthy, to open a medical business, rather than doing medicine as a lifestyle.
Service as a lifestyle. So there's a different approach. As a business, as something that makes their life easier versus a lifestyle where they're helping people. And
that's right. But I'm not blaming the system, Canadian system, because it's a very good, in my opinion, adequate system. Yes, it doesn't function well. Yes, it needs to be changed.
Improve a little bit,
the fact that everybody has equal opportunity to have services, maybe sometimes delayed, sometimes no services, but you have an opportunity, you have a chance. It's great. And the knowledge around the world that Canadian doctors and American doctors are receiving so much compensation brings many people here from around the world that's trying to open the business.
But I think
so it's not the system, it's rumors.
It's the rumors, yeah. So I want to go back a little bit into your own experience of going through medical school in Russia. Can you tell us a little bit about how that system is? Because here in Canada and United States, you have to obviously finish high school and do 4 years of an undergraduate program and then apply for medical school, go to medical school for 4 years and then do residency. What is the system in Russia like, and at least when you went to, or Soviet Union, I guess, when you went to medical school?
Right. So in the Soviet Union at the time, and it was universal for all Soviet Union, Ukraine, Russia, Latvia, Lithuania at the time, and it was a system that you go to medical school right after high school.
High school, right away, you come medical school. Okay.
But you would go to medical school and you have to pass entry exams. And entry exams not government-sponsored. It's in every institution, every university. They have their own commission.
So it's different. It's not standardized.
And it's not standardized, and it's personal. It's one-to-one oral exam. You're talking to a
from
panel,
high school going
after
into...
Right. It's a panel of 3 or 4 professors, and they're interviewing you on topics of biology. Then another exam, it would be physics, mathematics, and then you write an essay. Mm-hmm. And based on your previous average academic achievement in your school, and mainly exams that you're trying to pass in this university, they will accept you or not.
Mm-hmm.
And therefore, it was much more subjective. And the university could pick and choose who they wanted, by personality-wise. So if a university was attuned to have young people very empathetic, very nice, not mathematicians, not physicists, but more with knowledge in psychology, literature, they would choose these people. They would emphasize on literature, they would emphasize on biology, rather than on mathematics or chemistry. Then they will teach you what you need to teach. And that's why they would have 7 or 6 years medical education. There were first 2 years, you're getting general
science,
The same, like here it's 3-4 years in the
undergraduate
program. But then it's more attuned to medicine. And then you're going specifically to medical subjects, but at the same university that provides all this system. My understanding that in UK at the present time, you have 2 systems. One is, like I am describing right now, after high school, and another one is with bachelor degree. But
first and then medical school.
Then medical school. And it's more tuned for people that would like then to travel to the United States and to have clinical rotations in United States, not in UK, and then to try to pass exams in United States or Canada, LMCC, or American licensing examinations. Mm-hmm. So that happens. And going further, before you asking the next question, when I came to Canada, my medical diploma was not accepted fully, but it accepted as a allowance to take a qualifying exam that would qualify me or equalize me with Canadian graduates.
I see.
At that time, it was multiple choice, 7 hours exam. And when I passed it, then I was told, okay, now you will take other exams like Canadian graduates are taking. And all these exams were very different from my ever experienced in Russia, because all these exams were multiple choice.
But in Russia, exams are
99%. It's
written?
It's oral.
Oral, oh.
You're taking subject, and then you talk to panel of professors, and they can ask you any questions. They ask an initially question that you chose, like 3 questions. There is a tickets, and you're choosing it, and there is 3 subjects. Let's say in surgery, gastroscopy, cholecystectomy, or some other problems. You talk on the subjects, but then professor can ask you any questions. And
which one do you think is harder? Multiple choice? Because that system, I think sometimes people get nervous.
Absolutely, you're right. You're getting very nervous. And plus, if you did not attend the lectures for this professor, you don't know what he's asking about.
So it seems like it's a harder, like you have to...
there is no harder or easier, in my opinion, because it's a system in Canada and United States, multiple choice questions, it's covering so much material. Now when I am probably in the end of my career, I don't know how did I pass it. I just can't imagine that I passed all these exams.
And it's getting harder and harder every year as well.
But even at that time, it was mind-blowing. How can I remember all this stuff? But for young people, don't worry, they will. Just go.
Go. Persistence.
Repeat. Then it comes by itself. You develop intuition, and you're learning how to answer these questions. Sometimes, even if you don't know, it calls educated guess.
Educated, smart guess,
But its educated guess becomes so good that it helps. Now, it becomes a challenge when you go to residency. You finish medical school, you go to residency, and again, you're trying to guess.
You can't guess.
Bad idea.
You can't guess in residency.
Then when you become a doctor, you cannot guess. You don't know, you're saying, I don't know.
Yeah, there's no gray areas, black or white. You know it, you don't know
right.
it. If you don't know it, you have to like go find out or ask or...
And you know, the difference was 30 years ago, that now you just open your telephone, you have everything on your palm to get all information what you don't know. Previously, if you don't know, you have to go back to library to search huge amount of time to
investigate a question.
And when you're trying to pass these exams, you cannot just simply have multiple choice question. You don't know how to answer it, and you go to telephone to find the
you just put the question in and then get the answer right away.
Yeah, but you're going to a library looking for books to answer one question for a couple hours. It was really very a difficult task to prepare yourself for these exams. Now it's much, in my opinion, much easier. But it teaches medical students, it doesn't teach medical students to think in a way that you need to think in clinical practice when you
critical thinking
more
becomes
flexible.
A little bit,
That's right. And that's
because they can find the answer right away without even thinking about it or trying to figure out the answer.
And it's very good, by the way. But if you have a doubt, then you have to stop and make a pause and to go to clarify the information that you don't adequately know and not to guess it. It's very important. When I finished medical school in Russia, they allowed us to go to practice practically right away. 1 year it was rotating internship under supervision.
Yeah. And
then you're going by yourself. You're going to a remote area,
rural
alone.
Communities, by yourself.
By yourself, and you have to read the book, and you have to ask somebody questions, your senior doctors, and it's unbelievable. So in Canada, you have a privilege of working for another 5 years, and it's still remuneration, financial rewards. You're getting money of your resident. For 5 years,
as a resident, no, it's not a lot, but you're still getting something, right? Well, a lot relative, again, perspective.
It's still not you paying for that. You are getting payment.
You're getting paid and you're getting residencies. Basically, you're still getting trained, but you're getting paid for it as well.
So when I came to Canada and I was going through residency.
Because just to clarify, so when you came to Canada, you had to go to psychiatry residency again, right here.
Right. So go again a little bit back that I'm saying that in Canada, I was accepted having diploma, but I had to pass qualifying exam before I was allowed to move into clinical practice, and then I passed another 2 exams. But after LMCC Part 1, I was allowed to apply to residency.
At UBC, Department of Medicine.
There was only one residency at that time, but I couldn't. Because for many different reasons.
You couldn't, like, you didn't get in, or you didn't have space? So you have to, like...
At that time, there was no CARMs.
Oh.
They have 2 spaces, let's say. It was already for somebody.
So there was no, like, clinical space for you,
No,
so you had to wait.
And they were telling me, you don't need to wait because we have somebody for next year as well. But, so what happened in forensic psychiatry, they needed people. As I mentioned, the Canadian graduates were reluctant to go to forensic psychiatry because you had to work with criminals, psychiatric patients.
So that opened the door for you to go.
So forensic psychiatry, they said, okay, you know what, we can sponsor you. We can pay for you if after graduation you're working a year for us. I said I would love to do it.
You took the opportunity, yeah.
No, but I was interested in forensic psychiatry. I didn't have any issues, and I said yes, I would do it. And that's how
you got into the system.
Into the system, and then it worked. But I was accepted to residency, and the forensic psychiatry was paying my residency to the UBC.
Yeah.
At that time, they allowed us. It calls moonlighting. Moonlighting meaning that when you have a limited license, you can actually work at night.
Oh, okay.
Only in the hospital that you have limited license.
Yeah.
And I was allowed to work for forensic services, and I would still work for forensic services at night, providing care for patients that are getting admitted, writing admission history, initial medication. So I would go to residency, and at night I would work and transfer this money back to forensic services. So I am paying ahead of time that I'm not burdened by that I owe money. So my residency was very difficult because of that. But the residency was 4.5 years. And I was 35, 36 years old, then it was 38. And I was in residency with very young people.
Yeah, because of your background.
Because I came 10 years later.
Clinical practice,
And my supervisors were younger than me and less experienced.
How did that feel? Because
very bad.
That's a huge kind of piece, because it's very important for immigrant doctors, because I think sometimes it's very difficult if you've been in practice for so many years, because, you know, a lot of Iranian doctors, for example, come to Canada, and, you know, I know a lot of them that, you know, it's they have a hard time accepting that, the fact that, you know, they're heading a hospital surgical department right now, they have to come here, and, you know, their supervisor is, you know, someone's like 15 years younger than them or 10 years younger than them. What kind of a challenge is that, and what's your recommendation to?
It was a huge challenge.
Yeah.
You have to put your ego
aside,
into your pocket and forget about who you are and what you did before, put your head down and listen and work what they do. I didn't do it, unfortunately. I had my character, personality, and I got into troubles initially.
Can you tell us a little bit about that? So what was that like?
You know, the system here doesn't care about your background, who you are, what is. You have to provide services even if you're a resident. But I had 2 small kids. And at 5 o'clock, I need to go to pick up them from school. And if my patient was admitted to the hospital a little bit later, my supervisor wouldn't listen to me that I have to go to pick up my kids from school. I have to admit a patient to go to hospital.
You had to do your job.
I have to do my duty.
Doesn't matter what other responsibilities you have.
Right. And then if at the time of discharge, I cannot stay late in the hospital and patient discharged, I have to write discharge summary later on in Saturday, Sunday. And if your supervisor is a young fellow, younger than you are, recent graduate, 30 and you're 38, and you've been in forensic practice facing life and death threats in Russia. So you're harsh. Your personality, my personality was very harsh, and I wouldn't tolerate this kind of attitude when if I am saying I need to go home to pick up my kids, and he say, no, you have to write a discharge summary.
How did you overcome that?
So we had to have a hearing with the director of the program, and I was lucky that at the time director of the program understood my point. And they simply reviewed
your situation,
my situation, and they gave me remediation that I would learn how to be mild and mellow. Since then, I am mellow.
Fair enough,
except from when I'm going to court.
But
we need to learn to learn how to behave in Canada, that it's a completely different country. We cannot be harsh, we cannot be direct, we have to be diplomatic, and we have to learn how to work with the system and not to fight. For some people, it takes time. Some people learn it in a hard way. Some people learn it in an easy way.
So how did you learn to put the ego aside and eventually, you know, accept the situation, the fact that maybe you have, you know, 10, 15 years of clinical experience, and someone younger, you less experience, is telling you what to, how did you put that aside? What was your...
It was not only about experience, it was mainly about workload, about hours, and indeed about some of decisions. But I always respect the decisions of people that work in the system. But also I had very good supervisors, some of them, and you just always have a support from people around you in clinical setting. So maybe I was lucky, but I had Dr. Valens at the time, a psychiatrist also. He was from Great Britain, and Dr. Eves that I got to know. And some other doctors, Dr. Murphy later on, and with this kind of support, I am still grateful to Emily Murphy. She is head of forensic psychiatrist now, how she helped me to understand the system and not to be as rebellious as I was at the time. But it's a process.
So it's a process. You have to be persistent. You have to accept that it's part of a system, right? You have to get into the system and then just push through.
Absolutely, absolutely. But also, if initially I upset. Like you say, many doctors are saying, why do you need retraining? Why don't 4 years again to university? And residency, it's not only a clinical aspect. It's you have to pass exams, you have to go to read a lot of material, you have lectures. It's really intense at that time. And biochemistry, it was really challenging for me because I was 10 years after graduating. But now I understand it was necessary. Not only because of knowledge, because my knowledge from learning medicine in Russia was not as detailed as Canadian training, especially in the biology, neurobiology, chemistry, neurochemistry, organic chemistry, and but from ethical and moral perspectives, culturally, it's completely different country. And if I didn't
background training there,
huge difference. Background training in psychiatry gave me knowledge of pathology, as I mentioned to you, schizophrenia. Clinical presentation, patients with schizophrenia, depression, and other conditions are the same everywhere. Even with limited English, you would understand that the patient has some of the symptoms. But from cultural perspective, how to interview patient, how to understand patient's needs and the key words in his presentation, and to be empathetic and to express your empathy, not to be harsh as Russian doctors are. Or war in that time. Because if I have a unit, 3 doctors for 100 patients, you don't have time for empathy. You
just want to get
you're going
get
around,
it done.
You're going around the unit with nursing staff behind you. You see the patient 5 minutes and you're talking to patient to nurse changes the medication. Go next. This is not care. This is not quality of care. Here, it's emphasis on quality of care, individual approach, and that's what we need to learn. And it's a big difference.
Culturally. It's very interesting that you say that because when I practice and I see different types of patients, it's so different of how I approach different patients with different cultures. So, for example, Western culture versus Middle East. I'm obviously from Iran, and sometimes East Asian. It's like some of the patients, specifically, for example, East Asian, that I find from my experience is that they want to know the answer, and then the Middle Eastern patients sometimes they want to know what's the quickest solution. And the Western patients, it's more of an approach of what is the process like. So it's the way I present or even ask the questions or sometimes approach my, kind of clinical findings and the way I want to, pursue that dysfunction and provide therapy. It's such difference between cultures. So what is your experience like, coming from the Ukrainian, Russian culture, Soviet Union, and then the Western?
I still see a lot of patients from Russia, Ukraine, and former Soviet Union. And the former Soviet Union changed people. They have completely different mentality. They're asking for advices. So that's the difference. Tell me what to do.
Yeah, they want to know the answer, right? Like, tell me what to do. I want to do it.
I can't. Right? I'm a psychiatrist. I'm not a counselor, I'm not an advisor. My role is to bring a patient to the solution of a problem on his own. So he comes to a resolution or answering question by himself based on my interview. And they based on medications that I'm providing them, when they have relief of suffering, less symptoms, they have a clear mind to make decisions on their own. When patients are affected by depression, they have cognitive distortions. They see world in a different way.
Perspectives changed.
It's completely. And they are thinking in a negative way. Everything is negative and everything is in a gray zone. They don't see colors, they cannot be happy, and they cannot make decisions.
Yeah.
So the first, what I'm responding to my European patients, mainly Russians or from Soviet Union, former Soviet Union, I would say not to make any decisions now. When you're ill, put it aside until you feel better. So I'm not going to give you any advice except for medications. But then when you feel better, we can discuss. And very often when they feel better, they come in, I resolved it. No issues. Everything is much better. Now I can do it. My self-confidence is better. My self-esteem is better. I know what to do. But I learned this strategy only in Canadian residency. We were not learning this strategy in Russia because that's mainly medicine. Go. Prescribe medications, and that was
very quick, 99% very quick. Yeah, just what's the solution,
we
right?
Didn't have time because such a significant workload. And the second part is that I came to Canada and I started working forensic psychiatry, and I had to go to court, and then I had to court many times on personal injuries cases. It's part of forensic psychiatry, civil litigations. And my personality didn't change. I can subdue my being direct, but in the courtroom when another opposite counsel, lawyer is giving you such a hard time and insulting you and do whatever, you react, and you cannot not to react. So sometimes judges would say, Dr. Levin gave very unusual, very presentation. Being diplomatic, right? Because I didn't tolerate much of insults, let's say. But anyway, and when these personal injury patients, let's say, come in, they have expectation that you would write for them a report that is more beneficial for them. And I'm saying, listen, the idea is that I should be in between you and the court.
I see.
And if I am skewing and if I am biased, then it's not fair for me and not fair. But expectation from this part of patients, that I would do it. I would be biased.
So it's a different approach.
Right. So initially I actually was much more on opposite side, on defense side, on the prosecution side, more than on the patient side. And then I kind of doing more than 50-50, and that is balanced approach. But it's also very culturally intense environment when you see patients in personal injuries or forensic psychiatry, because from culture they have expectations from you.
Absolutely.
As if you're from the same culture,
now,
you should be doing this. You should do what I need to do.
Yeah, they want, sometimes I get that too, and I'm like, hey, you know what, it's not going to be like that. You got to figure things out together. So I want to ask you a question, because I personally, because of the nature of my type of practice, my treatment times are quite a bit longer. And so a lot of conversations happen in the room. And, a lot of times I always ask my patients, hey, what are you going through? What's your stress like? Because that does affect the pain cycle, especially with chronic pain. And I think a lot of good percentage of my patients, I'm always, asking them to either go see a counselor or a psychologist, or, go see a medical doctor and get a referral to a psychiatrist. But one of the biggest criticisms that I hear back from patients is that, I've tried it, but every time I go there, I sit down, all I do is I talk, they never give me any answers. I have to figure it out myself. That's the point that you brought on, right? What is your response as a psychiatrist to patients of why that process is so important for them to figure it out and for them to go through the cycles in their mind?
There is a big difference between advice and psychoeducation. Psychoeducation, when you are honest and open about patient's diagnosis. Then you explaining patient diagnosis and some scientific evidence behind this diagnostic opinion and options for treatment. Biological, which is medications, or psychological, which is psychotherapy. So this kind of psychoeducation helps for patient to understand where I'm coming from. When they're asking specific advice, what to do in the situation, once again, there is such a, for you as well, strategy is mirroring. You're not answering the question. You're asking question as a mirror, but making patient to answer it for you. And the same way, you're giving him opportunity to say right or wrong, doesn't matter, but it's his answer. So leading patient in the right direction that you feel would be right, but for this patient, he's choosing this way, is helping you and the patient to be satisfied from your answers. If you're saying, I don't know, it's not an appropriate question, or if you're just silent, it doesn't work. When I was going through training in psychiatry, at that time we were trained, especially in psychoanalytic psychiatry. We're not talking, we're only listening. We're not showing our emotions. We're not self-disclosing any information. Over years, it changed a little bit. But once again, I bring my cultural background into my practice. And for good or bad, I feel that I have better connection with my patients because I do answer some of the questions.
So you are more not just a pure listener, you talk, you have a conversation.
Much more than ever before. With age, I become more confident and less relying on guidelines, what I can say, what I cannot say. I have to be politically correct.
More experience as well plays a role.
No, because, by guidelines, I'm not supposed to say many things. But with time, you're learning how to say it politically correct and that not offending patient, that, you're always also afraid or concerned not to have any complaints to the college. And when you're confronted by patient, or you didn't do anything good for me, or you prescribed me wrong medications, or you didn't answer my call, you cannot say, I was busy. Or, you know what, go to find another psychiatrist. You cannot say it. You're taking it, you're explaining your position, you're explaining that you're not available in acute emergency care, and you're gradually, slowly resolving the situation. Definitely we have patients that are agitated, paranoid, delusional, that can attack you. That's why in private practice we are not seeing this patient, but when it happens, you have to be cool. You have to learn how to resolve the situation, how to make the situation less acute. Sometimes you have a patient who is suicidal, saying, okay, doctor, you can't help me, I'm going to kill myself. What are you going to do?
What would you do? That's actually very interesting.
Right, right. But you see, that's when patients are then complaining.
Yeah.
Because I have an obligation to assist this patient who is suicidal. And we're not taking it easy when somebody that I believe had previous suicidal risks, making such a threat is only being upset. And if I feel that the patient is actually at risk, I cannot let him go leave my office. So I'm saying, you know what, let's talk about it. I will try to help you. Meantime, I find a way to call ambulance and police. They come into my office.
Kind of like resolving this, you got to figure out how to resolve this.
They come into the hospital, they come into my office, taking this person to a psychiatric hospital, VGH, where I'm not far. And in the hospital, the patient has a chance for a second assessment, but usually stays overnight or a few days. The suicidal urges or ideations are decline or diminishing, and then they can be discharged safer, not safely, but not safer home,
not as
for further care.
Dangerous.
And then the patient comes back to me and saying, listen, doctor, you betrayed my trust. And I explain it's not only trust, it's your trust to me that I will keep you safe. And if you're suicidal, I'm here to save your life. And if it has to be like that I'm calling police and ambulance, it's to save you. Some people understand it, come back after that. Some patients not. But that's where you're saying that in psychiatry sometimes we have to confront patients.
Yes.
In other cases, that when my understanding of the patient's problem is not consistent with the patient's desire to have a particular diagnosis like ADHD, they want to be prescribed stimulants. And I'm saying, but you don't have this condition. And then patient is upset, can be insultive, can be agitated. You don't want to prescribe it to me, and all these kind of accusations. So different situations, a lot of challenges, and still still very challenging work, and the psychiatry is very challenging work.
Yeah. So, but in terms of kind of like the scientific, the clinical science that happens inside the brain, where the person has to figure out, in terms of like psychotherapy, I'm talking about that aspect of coming to you, and the process that takes a long time for reset and kind of finding that perspective, the patient finding his or her own perspective, right? Can you tell us a little bit of the science behind it, how the brain works? I think when people have an understanding of the process of the brain of restructuring, maybe that sheds light of sometimes why some of these processes are long, but at the same time, they have to figure it out themselves versus you providing the answer for them.
You see, it's a very complicated question. It's just more than one lecture.
Absolutely. But you have to like part 2 or something.
Psychotherapy is complicated, and the psychiatrists are not really equipped to provide psychotherapeutic assistance to patients as well as psychologists. Why? Because we're very, very busy prescribing medications, seeing patients one after another with medical conditions rather than purely psychological. So when somebody has, let's say, depression, moderate or moderately severe or severe depression, just psychotherapy is not going to help. Too late. In this condition, patient has, as I mentioned before, cognitive distortions. They see everything in a negative way. They have a sense of guilt, and they have suicidal ideations. Life doesn't worth to live like that anymore. And if you say, no, look, it's not like that, you're not going to change his mind. So the first step is to provide adequate medications that patient can feel a little bit better and could accept psychotherapy as a second step. Or in the same time, when he feels better, not yet much better, you can introduce psychotherapy.
So the first step is just to kind of like mitigate the situation, bring the situation down.
We're talking about moderately severe or severe depression, or significant psychiatric condition like generalized anxiety disorder when it's acute, in acute stage, or when it's also moderate, when patient cannot function. Then just talking, once again, because patient's brain doesn't process information in the same way that non-depressed or not anxious patient would do. These patients tend to exaggerate even small, minimal problems. And this exaggeration in their mind is not going to be affected by you telling, no, you relax, don't worry, go for a walk. Just don't worry about it. It doesn't work like that. So there is a cognitive behavioral psychotherapy. It's a structured psychiatric psychotherapeutic approach that has scientific base and scientifically proven helpful. All other psychotherapeutic interventions are less effective than cognitive behavioral psychotherapy. Cognitive, it's when you are recognizing somebody's cognitive distortion. When the patient describes your history, problems, and how he sees this problem. And you, as outsider or as a psychiatrist in this situation, you can see that there are flaw of the logic. It's not logical, but it's his decision. In a patient with obsessive-compulsive disorder, you also see where the obsession comes, obsessive worry, and why the patient uses these impulses, compulsions, with these obsessions to resolve anxiety. But if you're telling him, he said, I cannot do it, I just cannot force myself to do something else. So then you're saying, let's talk about what you're thinking, how you're thinking, can you write down homework? And this is a cognitive part. Second part is a behavioral part, cognitive behavioral psychotherapy, when patient, based on his cognitions and writing homework, he's trying to change his behavior. He's coming back to a therapist, and they're discussing success or not success in achieving different behavior based on his cognition. And gradually, slowly, his cognition also changes. And he changes his cognitive understanding or cognitive behavior, cognitive behavioral approach to a problem. However, in patients with depression, very often even when they get better, this stressful situation that triggered depressive episode are still staying with them. In patients with post-traumatic stress disorder, the trauma stays forever or for a very long time. And psychotherapeutic approach, cognitive behavioral or exposure or other psychotherapeutic modalities, they are not 100% helpful or significantly helpful. So now we have medication that we're using, the same medication that we're using in other more severe mental disorders such as schizophrenia, delusional disorder. It's major tranquilizers that are changing way of your thinking on the cellular, on the brain, on level.
Neurological levels, yeah.
Right. On the level of neurons, it blocks D2 receptors, reduces your preoccupation, your negative thinking, and your depression becomes less severe with antidepressant medication and augmentation with this neuroleptic medication.
So you're saying that it's just like a whole process, first from treating the acute symptoms to training the cognitive side and then the behavioral side, and then that'll reinforce it, right? And then maybe long term, you're also treating with medication some of these.
Absolutely. You see, there is an emotional component of depression and anxiety, let's say, and the pathology is based on the midbrain, mesolimbic system, and your behavior controlled in your frontal lobe. Mm-hmm. So when you're using medications to affect mesolimbic, frontal lobe, your behavior, and other areas in the brain, if you're using only one medication, it's not as effective. If you're using only psychotherapy, it doesn't change your neurotransmitters. However, it was very interesting research when they were measuring concentration or activity of brain with specifically to serotonin. You're taking serotonin reuptake inhibitors, selective, like previously it was Prozac or Celexa, Cipralex, or other medications. And they would do positron emission tomography and to see activity of the brain. When you're taking medication, and then they would check, provide the same test after psychotherapy. So for half an hour, you still have effect similar to medications after psychotherapy.
As if
but then it disappears.
Yeah. So the effect is not as long, but it's the same effect in the brain.
Very similar.
Very interesting.
So that's why they say there is a scientific proof that psychotherapy works, but there is no proof that it works for a long time. And it's no proof that it's going to change your cognitive distortions as much as a combination of psychotherapy and medicine. I'm not making a propaganda only for medications.
But it is important based on science what's been shown.
Absolutely.
Right? Yeah, that
and
you need
psychiatry went through so significant development in the last 15, 20 years, where you have functional tomography, a lot of positron emission tomography, a lot of research done. And if you're saying that, we don't know how the medication work or they work at all, it's not true. We know much more about it, and we know they work. You cannot treat ADHD without medications.
Yeah, and science is there to prove it, because I think that's one of the criticisms, or I guess, it's a bit of a taboo, for a lot of patients. Oh, I don't want to go see a psychiatrist or do any sort of psychological therapies because, I don't want to take these medications because I don't know what they do to me. But there's a lot of good science behind it.
Not only that, but you see, taboo is also, let's say, for stimulants, for the children. But it's like a miracle drug. Yes, it's a stimulant, but many parents are coming and saying, it saved our life, it saved our kid life. The same with generalized anxiety disorder. Patients are coming to family doctor for many years with back pain and headaches. Then they go to chiropractor, they go to massage therapy, and it's still the same symptoms. They are diagnosed sometimes with fibromyalgia, rightfully or wrongfully, we're not discussing it, but with all the conditions. Nobody can find, they send it to psychiatrist. You're saying this patient has generalized anxiety disorder, and anxiety generalized causing him muscle tension, headaches, tiredness, and back pain.
All aspects of that.
So now, diagnosis is one thing, but how to treat? And I'm saying the best treatment for this condition to start from is clonazepam. But this is a benzodiazepine, bad publicity. People say, no, I will be addictive. I will addicted to clonazepam. It's an addictive drug. But if you take it for 1 month and you feel much better, and it's also like similar to stimulants, it's like a miracle. Sometimes people start from this medication for a short period. Doctor, I don't have a headache. Disappeared. So then you're adding SSRIs, you're adding other medications for anti-anxiety medications, but introduction of this kind of medications like any benzodiazepines that have an anti-anxiety and a muscle relaxation effect can be very significant help for patients with chronic back pain, chronic muscle pain, and the medical conditions.
And these are all backed by scientific evidence and research, and it's getting better and better and improving, and so I think there's a little bit of disconnect between the science of it and what the general perception sometimes is.
And stigma, stigma of psychiatry, stigma of different type of medications. It's amazing, like young people are coming for ADHD medications. And you're saying, I would like to start from Wellbutrin, which is antidepressant, but very mild medication that also sometimes prescribed for young people with ADHD, instead of giving you Adderall, that they're coming to asking for Adderall, because in my opinion, it's not always you need to prescribe Adderall. And they say, no, I don't want antidepressant. Then you're talking about the history, and they're saying, yes, I like partying, I like sometimes a little bit of cocaine, or sometimes marijuana, and all this kind of stuff. And you're telling me you don't want to take antidepressant medication, but you're using all these drugs. Doesn't make any sense.
I guess, everything's a perspective. But I think, Alexander, we have to bring you back, if you don't mind, for a second time to actually talk about these specifics, and especially mental health and depression and all the science behind it. I think that's a huge thing, especially in society post-COVID. But for the time being, I want to go back to some of the main things that you mentioned about your, inspiring comments about your persistence and not giving up and pushing through and doing what you love, because that's what you want to help back and give back to the society. Now, in this segment of our show, we always ask our guests that if they go back in time, would you have wanted to become a psychiatrist? And if yes, what advice would you give yourself to the young Alexander? If not, what would you have done differently if, go back in time, say 30 years or 40 years ago?
Thank you. It's a great question. And, I'm completely satisfied with my career. And going back, I wouldn't change anything. I'm very grateful to Canada that I was given this opportunity to work in psychiatry, and especially in forensic psychiatry. It was an incredible experience. About the choice of psychiatry in my case, I don't see myself doing general practice because of repetitiveness of work. And when the young doctors are choosing what to do, they have to understand their own personality.
That's right.
And lifestyle expectations before they're choosing field of medicine. So in my opinion, psychiatry gave me a much better lifestyle than general medicine would have given me, or surgery or other area of medicine, because I do have more flexibility.
With your time,
I'm not bored at my work.
Oh, the stories you were talking about,
it's very exciting. I don't have any two similar or the same patients. I don't have patients coming with flu symptoms, 20 out of, 40 out of 50 patients. So that's why, talking about personality styles, my personality, psychiatry is more suitable for me. And that's why future doctors should assess their personality style and how it would suit
them,
future career.
Profession to choose. Well, that's fantastic, inspiring comments, and it's a great pleasure to have you here. I think we have to have you here for a second time to talk about some mental health issues and some of the science behind it. I think that's a huge, huge opportunity for people to learn from your experience and expertise. So hopefully we can have you here on the second show. But it's a pleasure to have you, and I've learned so much already, and thank you so much for being here. Appreciate it.
Thank you very much for having me over.
Thank you so much.
Thank you. It was a pleasure. Thank you.